Welcome now to the second session in our let's say special day program, which is titled Digital Health: Joint Vision for European Citizens and Patients. The program is inspired by the recent Digital Health Society Declaration, which is driven by Estonia, by the Estonian presidency of the EU. And we had in the first session this morning, we had already Aina Vikso, who is driving the process in Estonia. And he will also come back in the session after this one. So this will be with us as a day theme. Now we will switch to one of the key subject of this work, and which is also currently under much public debate, both in Europe and also in Germany. It even went to the press as one of the subjects being discussed by the so-called Jamaica, or by the foreseen Jamaica coalition. This is all about the patient access, online access to their health records. We are dealing with the subject now under the European perspective, so towards accessible electronic health records in the member states. And it's my pleasure to welcome here representatives of two neighboring countries, which is Austria, represented by Dr. Günther Rauchegger. Dr. Rauchegger is the managing director of ELGA, which is the National Competence Center in Austria, responsible for all eHealth services, but of course he will explain to you much better. Then we have Dr. Carine Bonen, a medical doctor from Belgium, from Flanders. She is Flanders Care Coordinator and will speak later on to us on digital health and care in Flanders. And then we have two presentations from Germany. One here to my right, Dr. Robert Deiss. He works in the University Hospital of Aachen. And Aachen, as you know, is in the so-called EU-Regio. And so there will be one focus on electronic health records in Germany, but also with some cross-border perspective. And last but not least, I have here to my left Andreas Grode. He is head of innovation at Gematik in Berlin, our national competence center for eHealth. And he is responsible for many things, also for the new directory for standards, VESTA. Today he will focus on CEF eHealth towards cross-border sharing of EHR and medication data. So thank you for the speakers to be here with us. And it's now the part of Dr. Rauchegger to speak to us on ELGA in Austria and perspectives to cross-border eHealth services. Thank you for coming.
Well, thanks for the invitation to be here. Dr. Schug, it's a pleasure to be here. Also, it's of course challenging to present ELGA in only a few minutes. So I try my best to give you a little bit insight what we are doing here in Austria. When we talk about ELGA in Austria, about the electronic health record in Austria, we are talking about two basic principles. It's quite easy. The one is the kind of the method of communication, as you know, perhaps, and that's nothing else in most countries. We have a kind of bi-directional communication. A sender A sends to a receiver B some documents, and everyone is depending on the sender that he gets his information. That's, I think, nothing new. And the basic method we have in ELGA, in any electronic health record, I think it's not something really surprising that we have a kind of communication or information pool that you get your information when and wherever needed. That's a typical basis for electronic record. The second principle survived in ELGA is that we also define the content of communication, meaning, you know, perhaps my doctors, you can read this, not me, is that we change all, or we standardized all documents that are available within the electronic health record in Austria. Meaning we have some clearly defined specification about all the content, all the documents within ELGA, with of course these technical, let's say, properties, meaning you can automatically process this information. You can transform it, for example, for a view on a screen, on a printer, whatever. And behind is a kind of CDA document, a XML structure, a technical document, which is translated or transformed into a human-readable document. That's the more challenging part of those two basic principles. The one is the method of communication, and the other one is the content of communication. When we talk about content, we're talking about the discharge summary, we're talking about current, right now, up to now. We're talking about the lab result report, we're talking about the radiology report, e-medication, and some other documents. ELGA always comes into place when it's cross-sectoral, meaning inside a hospital, ELGA doesn't has any function as we're talking about borders of institutions. Meaning what we need at the discharge, the discharge summary, of course, we need for outpatients, for example, the lab reports, the radiology reports. For example, it's not necessary to have any lab results during a, let's say, 2 weeks stay in a hospital. That's not necessary. Finally, we need a discharge summary, including all the relevant information, not more, not less. That meaning for inpatient treatment, for example, the lab report is not necessary. And of course, we're talking about many other documents in ELGA, like the outpatient nursing report and whatever might come up in the future. That's open. One final step might be, or we are talking about, is the patient summary, of course. Deriving all, as we have a lot of highly structured documents, technically, let's say, processable, and finally we would like to compile a kind of patient summary that you might get insight on the whole content of the document. From an architecture view, we have more or less our already existing hospital information system, clinical information system, whatever, and they're still working as they did in the past. They're creating, storing, whatever, retrieving the documents, and we do interconnect these systems to our, let's say, electronic health record. We are using a kind of access facade, meaning we have a clear entrance portal to the world of ELGA, using what we call ELGA domain. More or less, it's from a technical point of view, XDS affinity domain, as we're talking about IAG. And of course, we have a lot of, let's say, central components that are used to primarily, one side, identify every stakeholder in this whole ecosystem, meaning you have a master patient index for all patients, you have also a healthcare provider index for all physicians and all hospital and whatever is necessary, and you have, or we have, of course, a access control system, since the access to these documents is, of course, highly restricted. Clearly depends on in Austria on a legal basis. This has to be fulfilled by this access control system. Well, the two things that might be possible is that on one side the patient gets all this information, all the patient, and of course it's used to exchange information documents between healthcare providers. That's the two main, let's say, user stories that are realized with ELGA. Well, ELGA is up and running since December 15. We have right now, these are the numbers from the end of September. Right now we have already passed the 10 million documents, meaning it's working on a regular basis, meaning every discharge is already, or the discharge letter of every dismission is already stored within ELGA. As we have an opt-out system, meaning every patient is by law already included in the electronic record, you have also the possibility to reject or to opt out from the system. Up to now, and this number is quite stable, these are only done by 3%, meaning 260,000 people in Austria. Well, and what's the perspective, as we're talking about the perspective to cross-border? Cross-border means that there are some, let's say, principles that should be followed when we're talking about a European community. On a technical level, it's the separation between application and infrastructure from this interoperability framework slide. When we look at ELGA, you might have the same as we have the application as creating, storing, retrieving the document. We might have this upper parts, this infrastructure as this IT infrastructure as defined on a European level. That means ELGA already is based on this segmentation, on this technical segmentation as proposed by the European Commission. That's from a technical point of view. On the other side, as we're talking about the content of communication, when we talk about content of communication, we are talking, of course, in terms of interoperability on a technical, but also on a document, on a semantic level. And therefore, we are strictly, and therefore we have all documents, of course, formalized and specified. We are talking about a syntax definition, a semantics definition, and of course, also using well-established terminology. For example, ICD-10, line encoding for lab results, whatever. On a technical level, on a process level, we are using IAG, integrating the healthcare enterprises. All these are well established, also on a European level, well established technologies and standards that should be, or that are used in Austria for the electronic health record. As the Digital Health Society Declaration was already a topic in the morning, one is that the citizen should be able to control all the data within an ELGA. This has been realized with ELGA from the very beginning, meaning a patient has in Austria, complete control about over his electronic health record. I would say he can do everything he can do also on what he can do with paper letters or paper-based communication. He can delete it, meaning you can throw it away, you can hide it, you won't show it your physician, whatever. You have a complete control above all your document, including very detailed access control possibilities. You might, for example, hide single documents, you might delete single documents, you might also restrict access to your electronic record to some specific healthcare providers. So complete control is one of the major issues. This is realized by, and these are already my final slides, by a web access. We offer a web portal where the patient gets insight into his own documents and where he can see his own medical documents. They are not restricted. They are in time displayed in this electronic health record. And of course, he gets also, for example, an information overview about his access log, meaning whenever there's a transaction in ELGA, the patient knows what's going on, as we have a complete overview about ELGA and all the transactions that are happening in ELGA. So that's more or less a very, very quick overview about what we did in Austria. The system is up and running in the meantime for nearly 2 years. It's stable and it's really a routine application all across Austria, meaning from the west to the east, from the north to the south. Well, thank you.
Yeah, thank you very much for this really high information per minute presentation. No, it was really very informative. And I've actually, personally, I've never seen this patient view of ELGA before. So that's and here it's really interesting to see what the patient will see and and it's clear what he can eventually do. Just one quick question. I think then it would be good that we see first the other examples before we go into maybe a more detailed discussion. You say that a citizen patient can delete also records, but does it mean that you would delete, let's say, the original document, lab result, X-ray, or is ELGA a repository of copies?
ELGA itself is the communication infrastructure, not the not a document repository itself. Meaning, when you delete a document, it will be no longer available by the means of ELGA, the electronic health record. Of course, it's stored in its original repository, meaning, for example, in the hospital for 30 years. Of course, that's not related to the access control to the deletion of a document in ELGA. These are completely separated matters, meaning ELGA is the communication pathway. And you delete this document that cannot be longer exchanged using this information.
Okay, thank you very much. Okay, we will come back later on. Now it's my pleasure to invite Dr. Karine Bohnen. She's the coordinator of Flanders Care, which is an innovative platform in Flanders. And she will now do a presentation on digital health and care in Flanders, where we will, of course, according to our main theme, also learn something on the system VitaLink, which a system that's also used to a little bit like ELGA to exchange patient-related information. So thank you for joining us, and your presentation should be up and coming if you need it.
Thank you so much for the invitation. It's an honor for me to speak to you today about this very important topic, necessarily to extol a large quality of care. So a very short introduction about Flanders Care. Flanders Care is a transversal policy initiative of the government of Flanders. I will tell you about it just to understand what we are doing. 4 ministers are involved in the program. The Minister of Economy, Innovation and Research, the Minister of Health and Care, the Minister of International Policy, who happens to be the Minister President, and the Minister of Budget. To understand what we want to do and what we want to reach with this eHealth program and with VitaLink, it's important to tell you that our public sector in Flanders is forward-looking and future-oriented, because there are so many initiatives on the short term, and the government has decided that it's very important to take initiatives who can be sustainable, who can be not only very interesting today, but to have a longer perspective and a longer view and a vision on the future. So, of course, the challenges are the same in every member state of the European Union, but it is important to take this overall vision with a longer perspective. So Flanders Care is where science and technology meet entrepreneurs to measurably improve quality of healthcare and welfare through innovation. And that is in fact the core business of what we are doing. The idea of hyperconnectivity, wearables, electronic health records, ICT backbones and cloud use is of course a very important building stone of this lifelong integrated care. It starts with the patient just has been born, and it ends of course at the very last day of his life. And what we want to have with this system that I will going to tell you about in a minute is in fact this lifelong integrated care. It's very important to work together with entrepreneurs, with strategic research centers, with healthcare sector, caregivers, persons who need care. So this cross-fertilization between the stakeholders is necessary, and especially not to forget the patient, because it's all about him. And the word patient is in fact an old-fashioned word in this case, because we want to arrive at a system where we don't speak about medical records anymore, exclusively medical records anymore, but about all records about a person, which is totally different than an isolated medical health record. Quick overview over the timeline. You see that we started in 2005, and I will take you to this journey, starting at the very beginning, more than 10 years ago. So with the creation of the first inter-hospital networks, it were local initiatives. There was no connection between the different networks. Every network has its own architecture and its own set of rules, and there were a lot of cultural differences between regions about patient-centered primary care. So it really was difficult. It was very local, and we wanted to have an overall network where every caregiver could speak on a safe and secure way about health data in the whole region. In 2008, so notice that it is more than 3 years later, we had the creation of a national eHealth platform. And to create this, it was very clear dogma that was put on the table in that time. So organize and support the electronic data exchange between all healthcare sectors, guarantee the information safety and privacy of the patient and caretaker. And so this was a very important issue. We wanted services related to encryption and communication. 2010, 2 years further, we had the very important conference on the priorities of primary healthcare, because so far it has always been a history of hospital and relations between hospitals. But on that very moment, it was understood in Flanders, both from the point of view of the government and the point of view of the caretakers and the caregivers, that it should be primary care organized and primary care related. So the bottom-up approach, the better cooperation, and this resulted in the building of Vitalink. Vitalink means, in fact, the connection, the link between every aspect of your life, Vita. That's what the name is meaning. Why Vitalink? To safely share medical and welfare data 24 hours, 7 days. To improve cooperation, because we think that the age where healthcare was very isolated should be history. We focus on the primary care and we put the patient in a central position. The core concepts, it's a digital platform, in fact, not a software package. The goal is to have a better multidisciplinary cooperation and better care, of course, and the data safety and the privacy regulations are crucial. So Vitalink is accessible for the healthcare provider through his own familiar software. This was very important because we noticed that 20% of all GPs, for instance, did not have experience with a personal computer. And those who had experience absolutely thought it was very important that they could use their own software, which they were used to. This was a very big challenge. You could not say from the point of view from the government, from tomorrow you will take this software and that's it. This was impossible. So we had to learn and it took time. Here you see how it looks like if you have the medication scheme, which is one of the first modules organized in Vitalink. So you see that there is real multidisciplinary cooperation. It gives a realistic view of the real-time medication of the patient. This not only the prescription, but also you can see whether the patient really has taken his medication, which is very important for the nurses who can cooperate with this scheme in their own records. Another module is the SUMER. The SUMER is an abbreviation of the Summary of Medical Health Records, so summarized electronic health record of the GP. And it was very important to give this message to the GPs. You don't need to do anything. It's not complicated. It's just a program that you should be able to create and consult this document without doing any efforts for it. So it was integrated in the software package of the GP. Another example are the vaccinations. So you see that we have VacciNet, which is the system for ordering vaccines, linked to an operational vaccination registration, which is very important because patients, they mostly don't remember which vaccinations they have. All of a sudden they want to travel and they are wondering, what do I need? And did I get it already? So it should be accessible for all vaccinators to improve the quality of the vaccination program and raise new possibilities for its evaluation. It's in production since 2005. By 2010, registration by GPs, pediatricians, well-being clinics, and school medicine. And 90% of all yearly given vaccinations for child, so by child we mean between born and 18 years old, are registered, which is a very high percentage. And since 2015, it was mandatory. So it's really better now. We have nowadays 5,450 GPs that are connected, almost all pediatricians, well-baby clinics, school medicine, travel vaccinations, and of course, Vitalink allows the patient and his care professionals to access his own vaccination scheme. Timeline end 2013, we had the first national eHealth roadmap. National means we are living in Belgium, so we have a federal state with communities, the community of Flanders, the community of the French-speaking people. Then we have also Brussels, the capital of Belgium. So we have, in fact, 3 types of rules, and it was a big challenge to make a system that could communicate with all those regions. Because patients live in one region, but they work in another region, they have holiday in another region, so it should communicate. End 2013, we had the Vitalink pilot patient empowerment, because if we want in our political vision that the patient is empowered, then you must give him the tools to get his information, to see his information, and to take initiatives to get a better state of his healthcare. This is what I mentioned earlier. You have Intermed in Wallonia, BlueSafe in Brussels, and Vitalink in Flanders. And they all communicate with each other. So you see then an overview of the connecting networks. The university hospitals with their hubs, the other hospitals, the GPs, the pharmacies. And then in 2014-2015, with the new eHealth roadmap, time has come to introduce a little bit of change management. We created eenlijn.be, which is the Flemish word for primary care, with training and support for healthcare professionals, with legislation, and with startup for a Flemish agency specialized for collaboration and health information exchange. Some cluster projects have started. New Vitalink models have been built in 2015, available in 2016. The cancer screening was integrated, and the results were available not only for the doctors, but also for the patients. In 2016, the hospitals were connected to Vitalink via the hubs. So it was not only primary care, it was also hospital care. And there was a direct integration of Vitalink in hospital software. Then I'll show you some facts and figures in 2017. So you see that the line on the slide, it's really very growing fast. And in September 2017, we have got 6.3 million patients with data in the system. The number of patients with a summarized, a sommaire, it was 1.46 million, which was growing fast also. Then you see the number of persons with a medication scheme, which I showed you earlier, 348,000. The number of patients with vaccination data, patients or persons, because not everybody is a patient, but most people have vaccinations. The number of GPs and pharmacies using Vitalink. It's very important that pharmacies are using Vitalink too, because they are able to see the medication scheme and they can give advice to their patients if they see that they had prescriptions from different doctors with maybe not the same meaning or the same goal. You see 3.5 million consultations of Vitalink each month, which is for Flanders a large amount. Then you see the timeline 2015-2018. The eHealth National Roadmap was rewritten in a 2.0, and you see here the priorities for Flanders. Electronic health records from GPs and nurses will be shared. So not only the sommaire, but the whole medical record. Medication scheme available in all regions, so Flanders, Wallonia and Brussels. All hospitals have an EHR connected with Vitalink. Consultation from within all hospitals in Flanders via the hubs. And in 2018, also updating of information like medication. Because nowadays it's a moment, but we want, of course, an actualized system and given information that is so recent as possible. And then elderly care organizations are taking the same train now, and we want, of course, to have them in the system too. Another challenge is the introduction of mobile health. A GP, of course, is not going to his patients at home with a computer and a printer, etc. Thus, we want to have an accessibility on mobile manners, and the healthcare providers and the patients will be able to make use of trusted and officially registered mobile health apps to do so. And of course, the registered apps will have to fulfill the highest standards regarding privacy and especially a big challenge, interoperability. They need an EU label for medical devices and evidence-based medicine, and only then we can be sure that the quality is okay. A slight overview of the market creation at a glance. So you see the different partners. And of course, with this system, Flanders is seeking for international partnerships. Flanders stands out as an economically sustainable and caring society, and we want to take the occasion here to look out for international partnerships to build further on this system of sharing data. In a European context, we work together with the Enterprise Europe network and especially with the sector group healthcare, who is taking place on this messe also. And my colleague of the sector group is here in the audience. So if you have some questions afterwards, you can ask her. And then we will deliver you the contacts of the persons who are really specialized on this topic in Flanders. It's not very good pointed, but Mr. Dominique de Jonck here, and I have put this email can help you with more detailed information, and these are the contact coordinates of the persons of Flanders Care.
Thank you very much for this interesting timeline. Just one, so if I understand well, there was one, let's say, there was obviously one, at one point in time, or at least it looked like, where there has been a project been running in Flanders, and where it became a national project, or has it been a national project from the beginning? And that was not clear to me.
It was due to the difference in competences of the federal state and the communities. It's not always very good organized, but in this time it was at the same time that initiatives were taken at the regions. And the federal state has, on a certain moment, said it should be safe and secure data exchange in the whole country. So let's bring together all the initiatives in the regions and let's create this first eHealth roadmap.
Okay, so it was kind of a synchronicity of the various streams. Okay, thanks a lot for the clarification. Okay, to get the full picture, we will move on to the speaker to my right, Dr. Robert Dijs from Aachen University Hospital. He will speak to us on EHR as enabler for eHealth and telemedicine in the EU-Regio.
Dear Chairman, for the kind invitation, ladies and gentlemen, welcome to this session. I will give you a short hands-on experience from the University Hospital of Aachen, how we deal with the telemedicine issues and how we use electronic health records to enable telehealth projects. What we are doing is, since 2 years, we are running a telemedicine center in the facility of the University Hospital in Aachen, and we are doing, since 2012, telemedicine rounds. I take you to a short tour. This is a view to one of the regional hospitals with our colleagues, and they are connected to us with a card like this that you see on this picture. And we are sitting in front of monitors and have a view to the patient data and to the audio-video communication. Both connection channels are secured under the highest standard, so via VPN connection and maybe additional, the minimum standard is end-to-end encryption, but historically we use both VPN connections plus end-to-end encryption. And here you have a look in one of the other rooms where two of my colleagues are doing one of those tele-rounds, and we are offering a telemedicine consultation service in intensive care medicine since 2012 from a project called Telematics in intensive care medicine, and we now run one of Germany's biggest innovation funds projects, the so-called Telnet at North Rhine-Westphalia consortium, and this is one of the pictures from our daily work. Now back to the EHRs. Our interpretation of an EHR is not a real lifetime health record. It's quite similar to what you've heard before. It's a system which we call EFA, which is the abbreviation for a electronic health record on a case basis. So it's not a lifelong documentation artifact, but it's a communication point where the general practitioner, the hospital doctor, the family doctor, and also the patient can decide which documents are stored in this portal. All have access, they are all thoroughly identified, they have a clear role concept, who is allowed to have a look to those documents, and it provides a rapid access to the relevant documents which you need for the respective case. And I'll now take you to a journey of what we were doing. Of course, if you offer a single platform or a platform that is based on a case, you need a regulatory surrounding or a regulatory rule. And this was done by the EFA Association, which is a non-profit organization. It's an association of health tech industry plus Fraunhofer Gesellschaft and data security officers from more than 8 federal states of Germany who defined the specifications for this electronic health record. As you know, we have, even before the health legislation and the data protection novelization, an extensive data protection rule in Germany, and one of the challenges was to fulfill all legal requirements and, on the other side, improve the issue of interoperability. Due to those standards and this conceptual framework, it was possible that more than one provider, of course, entered the market. We have more than 20 certified providers for this electronic health record solution, which is fulfilling the EFA specifications, so the requirements for the interoperability, for data protection. And this gives you a good idea, this overview, about the communication channels we are using in daily business, and the communication needs this electronic health record are based on case records is supporting. We are able to communicate with the general practitioners via a safe communication network by the Association of Physicians. We are also able to communicate with the general practitioner via a web application and also via technical interfaces which the medical information systems of the private practices are offering. The next thing we have, of course, a direct communication channel to the university hospital, but also to other hospitals in this EFA association, and we are able to communicate to rehabilitation hospitals too as well. This gives you a good overview about the rough architecture on the one side, on the other side about our projects. You find here THM, which is the telemedicine project, and we have defined a few use cases. We have in North Rhine-Westphalia more than 20 use cases for the electronic health record. To give you an idea, we have tested and implemented the electronic health record for telemedicine in the ICU, for rehabilitation projects in the context of trauma surgery rehabilitation for the elderly. We are dealing with an artificial heart project and artificial heart patient rehabilitation, also based on the electronic health record. We have been running successful palliative care projects, which are highly intersectoral and highly patient-centered, of course. And over the times, we have more than 40,000 electronic case files, more than 250,000 documents, and the number is increasing every day, I would say, alone in the field of intensive care medicine by more than 100 patients per day. This is a short overview of the Telnet project to give you an idea that this concept is feasible for a large number of hospitals simultaneously. That means both telemedicine centers of the University of Aachen and the University of Münster. We are serving, each of us, more than 8 hospitals, which we are consulting on a daily basis in intensive care medicine and infectious disease. And we have a common infrastructure, and during the office hours, so night times and on the weekends, the University Hospital of Aachen, the Telemedicine Center, takes over the responsibility for the patients in the entire network. So it's a seamless handover of information between 2 telemedicine centers, not only between 2 doctors or 2 hospitals. To give you a short summary, the original intended use of the electronic health record was data exchange, information exchange, and not so a lifetime medical record. But we could easily modify it for telemedicine projects, And this is, I think, the common ground between all three projects we have heard so far. But to get the overview to this enormous technical framework and the organizational framework, this is a short picture. But the fact is, you can also, thanks to its scalability, easily use it for projects like telemedicine. And a really short overview, we started in 2012 with a number of 4 basic documents for intensive care medicine, and developed then this entire document set up to 6 documents, and it's more or less a total paperless ICU record based in the electronic health record. We modified it through this telemedicine and intensive care medicine project 2, and our next step will be the deep integration into this network. This is a little bit complex, but we still use the electronic health record Fallakte Plus as a kind of information broker. It will accept all the data from the information systems of different hospitals. It will also integrate the vital sign monitoring and transfer it to a patient data management system, which is centralized, and then feeds anonymized data to a research database or to the respective business intelligence portal of the single hospital, which is connected to this system. And the advantage of this construction is, or the setup is quite evident. We have a very short period of implementation. The customers of the Fallakte Plus just pay 1 integration channel from their systems to the Fallakte, and then the Fallakte consortium cares for the other systems. In my opinion, this entire concept from the state of North Rhine-Westphalia to rely on these case records and to allow different case records adapted to use case is highly efficient. It allows us to establish really customized solutions with an excellent interoperability on the technical level. We have successfully avoided a vendor lock-in and have an excellent price to performance ratio. For me, the most important thing is, from my experience, if you are planning to initiate a telemedicine project, like in a complex field of telemedicine, you want to bother yourself with complex IT infrastructure. You can just take a reliable and proven infrastructure and more or less kickstart your own telemedicine project, and then hand over the information to the respective source systems so that you don't have to keep all the data in your system. Thank you very much.
Thank you very much, Dr. Theis, for these insights to Aachen and the so-called Fallakte system. I will now immediately switch on to Andreas Grode, because we are a little bit running out of time. Andreas will speak, as mentioned earlier, on a little bit on the CEF project and the theme of cross-border sharing of EHR medication data. Andreas.
Yeah, thank you for being here. Thank you to give you the opportunity to look a little bit more inside what's happening in Europe concerning eHealth. My role in Germany is a little bit different. I'm head of innovation in Gematik, which is responsible to build up the German eHealth infrastructure since many years, and that's my direct connection to this project and this activity that's also lasting for more than 10 years now. I'm involved at Gematik for 11 years, so since the beginning, and in that role I was also involved in setting up a project which is directly, more or less, giving the reason why we are sitting here and why we're talking about eHealth in Europe. Before I go ahead and looking into the details of CEF, and thanks for one of the speakers before, Tapani, who already announced from the Commission that they are supporting that. In fact, they are more than doing this. They're financing that. They are moving us, all the member states, to make it possible that a European inhabitant can be treated in healthcare despite he's not in his own environment at home. And that is one of the main challenges. If you look at a patient who is getting ill unplanned in another country, not speaking the language, not having a patient summary or something like an electronic health record at hand at that very moment, he's more or less helpless and a little, well, despite he's going from Germany to Austria, then of course there's no language problem. Well, normally. On the other hand, if you move in another country, even if you would have your patient summary or an eHealth record with you, think of a Spanish doctor having a German health record in front of him, I'm not sure if he would be able or even it would be useful to use that document. So there are many challenges that need to be tackled. And the last challenge is, and look back 10 years, where, well, maybe you can imagine maybe that there was a different situation where eHealth could be funded or grounded off. There was no internet like we have now. There was no mobile access that we have now. But on the other hand, there was a need to have reliable information on the doctor's desk from a person who's unknown to him. So how to get the data to him with a person that's sitting in front of him just saying, okay, I have something, whatever, I need medical help. And that is the situation we faced 10 years ago, where a big project came up. Who has already heard of APSOS or SOS? Of course, there are some, well, colleagues from the ministry. That was a project that was the basis for all of that. Starting with 7 countries, at the end we were 25 countries all over Europe, with 45, more than 50 partners at the end, trying to find out what is the way to go forward. And what I'm telling you now is the result of that 10 years later. The project lasted until 2014. And if you're now not looking at APSOS, if you search for APSOS, of course, that's a project that has been a large-scale pilot to find out how to connect different member states' infrastructures without changing everything. Of course, it is not easy to say, well, we want to have every data accessible, but we don't want to change all systems in the national environments. That's simply not possible. Nowadays, we're talking about the so-called EHDSI, so the Digital Service Infrastructure. That is a screenshot, to be honest, from the Commission's homepage, or at least from a supporting page, and trying to introduce a little bit. And on the other hand, exactly my timeline for the speech I gave. If you look at the on the right down corner, there's what are you looking for? That's the main question if you want to enable eHealth in Europe. You're looking for reliable data on the doctor's desk, still preserving data protection, data security, still knowing who is the person in front of me, because you want to avoid that someone gets data that not belongs to him. And that is a challenge all over Europe we want to solve. I will tell you a little bit, not into the technical details, how that will happen. 10 years ago, and I think nowadays the impact is still there. You don't have an advantage if you move complete medical eHealth records from one country to another, except that's exactly the use case for a planned treatment that could be helpful. But for an unplanned treatment, it's just more or less only needed to give a patient summary to a doctor, which it holds your medication. If you have chronic diseases or other problems with you, then it's important, or if you're not able to get a special drug, then of course it's much more important not to have the complete history of the patient, but the very, very important things. That is what we called the patient summary. Switching back from the past to now, nowadays, and it was already proclaimed, it was already said that interoperability is one of the major things in the European eHealth agency. This is one of the things. The patient summary is now being standardized, is now being, well, internationally standardized as a European standard. So that is one of the results of that idea 10 years ago. The other use case is, of course, e-prescription. So if a patient has a medication prescription with him, he wants to get the medication in another country. Quite easy, but not as easy as it seems concerning the name of the drug, which is well, prescribed in Germany is completely different to that what a patient will get if he's in Spain. Even the names of the drugs are sometimes, so the substance is sometimes changing from country to country. Quite dangerous. I think one of the famous examples for that is aspirin, which is something completely different, at least concerning the doses. If you walk over to America, where you can say, okay, there's a much lower doses of aspirin, and if you take one of them in Germany, it's okay. If you take 10 of them, like the Americans do, it's not okay, because it's really harmful to your blood. On the other hand, those both use cases were those we were focusing at. And these two use cases are still the ones that are being introduced in CEF eHealth. So CEF was already a little bit pointed out by the colleague from the European Commission. I will give you just a short introduction what CEF all about is. So you know that the taxpayer is giving 24 million for CEF in everything. If you look into the details, that is being divided in 3 areas. One of them, and I only will look at them, is telecom. And in that, there's a small portion which is, well, designated for eHealth, 15 million. So the proportion is, well, looking at what has already been, well, achieved in eHealth, seems to be quite small. But on the other hand, this is well, a bunch of money for those countries who now not want to pay for the running of the system, but to build up. On the other hand, that means if the project or the funding is over, each country must have a known financial plan to run the infrastructure, which I will talk about now. I will skip a little bit the governance bodies that are needed to run such a European things. In the past, we had a normal project management architecture, which was led by Sweden and Germany a little bit. Nowadays, there's no project coordinator or project leader anymore. We have, from CEF, we have some bodies that need to be used. One is, of course, the eHealth network, which was already presented before, which is a body compiled of, well, politicians on the ministry level. We have, of course, a secretariat, thank you, Commission, which is providing the best it can to give support to enable decisions by the member states. And of course, there's a working body below, which is compiled of many, well, agencies like Gematik, for example, who is in charge to provide material decision support topics that the eHealth network can really move forward. For example, there's a guideline how to use patient summary in each and every member state in Europe. But as I said, it's not only a political thing, it's an IT project, or at least it has been. Nowadays, it's an IT, well, operation. We have to fulfill operation reliably. So that means if we have different roles, we have different partners that are involved in the operation of that European infrastructure. One of them is, of course, each country has to provide its own architecture, his own infrastructure, his own financing model, how to take care about that. But on the other side, there's a so-called central part, which is coming from the Commission, coming from Europe in this way, that is supporting the countries in special services that are needed, well, all over Europe. I will not go too into the details, but one example I will give you. If you think of a patient that is abroad, I would not need a laser pointer for, but I will try to move you a little bit through that slide. If you are a patient in a country that you don't know, then you are in that terms we use in a country B. Your country is country A, where you're coming from, where you normally live, but you're going abroad, getting ill, and you're just getting into whatever healthcare providers' offices in another country. Then you're in country B as a patient. The idea that still is on the table is that not the patient is the only one that can give information. Of course, there will be communication between the doctor and the patient. But later on, of course, there will be the need to get medical data electronically from the other country. That is country A, that's on the right side. Technically, that means there's a local IT, and you can imagine that no one can really force someone to change the local IT in a hospital. That's a decision, as we just heard, from a country, from a region, from a hospital. So therefore, we need to have the approach of a gateway. That is something that we call national contact point. That national contact point was invented by EPSOS, by that large-scale pilot, just to find out, okay, how would that component need to be built? I need to look at the watch, all right. And that is nowadays the infrastructure we're building up. I'm nearly in time. That timeline is a little bit outdated, sorry. There's a brilliant presentation on the homepage of the Commission, which is 99 or 91 pages. Of course, I cannot show you that, but that is some of the timelines that has been, well, borrowed from that presentation. You see, the main thing here is that we started in 2017 mainly. The funding goes until 2020. There will be a second call. Starting 2015 was the first one, and the second will start this year, or has been already closed, I don't know. And some countries are able to use that. In detail, maybe you can imagine that there's no possibility just to connect each and every country when it's ready. We decided to have 3 waves. So that means we have 3 possible, well, timelines where a country can choose to use that common infrastructure. One is next year in summer, not really February anymore, still February 2019 and still February 2020. The most countries that are really keen of being part of first wave 1 are now really well ready to do this, as far as I know. Germany will start in 2019 from the current planning. I will skip that. Last thing I want to mention, nowadays we're talking much more intensive about security and data protection. So there's a new thing that's coming up that's called TESTA. TESTA is a network between agencies on European level, which is quite long, and well, it's quite stable existing. And this is going to be very relevant for our CEF eHealth activities nowadays. That's my final slide. Thanks for your attention. If you have questions.
Okay, thank you very much, Andreas, for this interesting insight into the current plans and the implementation of CEF eHealth services. We are now already, I think we have just 1 minute left from the official time plan. I would be tempted to go 5 minutes over time. And actually, I would ask each of the presenters maybe to state, okay, in roughly 1 minute, where do you see actually the patient access in your solution? I think it has been mentioned to some extent by Karina and by you. I think it has not yet been mentioned by Andreas and by Dr. Dice. So maybe please try to summarize each of you in 1 minute the patient access.
Well, once again, patient access ELGA in Austria is a complete open system. It's completely open to the patient itself. It's a complete control of everything what's happening inside ELGA, what's exchanged across this network. We are not talking about separate storage in a hospital environment, of course, that's completely close to the patient. But when you talk about ELGA, it's a complete, for the patient, complete open system for the patient. We can do nearly everything, meaning he can withdraw, he can delete documents, he can hide documents, he can download documents, he can access the log files, meaning for every transaction what happens, storing, retrieving, whatever. It's completely open.
Thank you.
To make it short, it's nearly the same for the electronic health record, electronic Fallakte. What I have spared for the sake of time is that patients can register their identity, their mobile device to have certified access to their own health record. And they can upload documents. The only difference is a document which is uploaded by the patient himself has another level of credibility compared to a document which was generated from an electronic health record system from a professional institution. That's the only difference.
Thank you. Karine?
Thank you. The most important step we have put is the patient health viewer, where the patient can see his own documents, but on this very moment it's not possible for him to upload documents. Thus that is what we want to give the possibility to. But as I said, not only medical health records or medication schemes, but also information coming from his own mobile apps or from his own welfare environment. And that's in fact what we want to do as the next step.
Thank you. Andreas?
Yeah, looking at the European use case, if you are a patient that gets ill in another country, of course you can access, if you are able on that, and you have a whatever data access model on your mobile, then of course you can use it outside of your home country normally. But that doesn't help you, in fact, just because of the language we have normally using. If we have seen some, well, different languages on the screen, and that is a service that needs to be added somewhere in the future. There have been activities in AppSource how to make it able that a patient access is possible even with translation magically inserted. But that is something that is maybe the next step.
Okay, but besides the translation, he will have access as needed, or?
That is needed.
Okay, thank you very much. So, okay, since we are a little bit over time, I would close here the session. Thank you very much again, all the speakers. We had really insight in quite different systems, different types of stories. I think altogether, it's a nice snapshot of where both electronic health care records and, of course, the electronic health care records are somehow needed to be able to access them. So that's the other part of the story. So we have now the full picture. Thank you very much for the speakers. Thank you very much for the audience. And I close the session here.